So after we've done all of our tests and our imaging, and we've confirmed that there's possibly a tumour within the bladder, the next step is something called a cystoscopy. Now, a cystoscopy is looking inside the bladder with a telescope. Cystoscopies can be done under local anaesthetic, or they can be done under general anaesthetic. If they're done under local anaesthetic, it's called a flexible cystoscopy. That literally is just a look. It's not very uncomfortable. A little tube is passed through the urethra, which is the tube that you pass urine out of, and we can take a look inside the bladder. If we see a bladder tumour, what it then means is that at a second sitting you need to have an anaesthetic so that we can then deal with the bladder cancer by taking a biopsy of it. If we do a cystoscopy under general anaesthetic, when we take a look in, if we identify a bladder cancer or a bladder tumour, then we can take biopsies at the same time. And those biopsies are called a TURBT, or transurethral resection of bladder tumour. And with a TURBT, what we do is we introduce a telescope through the urethra into the bladder, and we can cut the tumour into tiny little bits and then take those little samples out and send it to the pathologist to have a look at under the microscope. Complications following a simple cystoscopy are very rare. Most patients will experience some burning and stinging for 24-48 hours afterwards, and you might get some blood on and off for about 24-48 hours afterwards. But if you've had the next step, which is the TURBT as well, then there is a raw area in the bladder. And for that raw area, it will normally ooze some blood for about 24 hours. So often what happens after a resection is that you'll have a catheter put in which irrigates fluid through your bladder. And once the oozing has stopped, we can take the catheter out and the patient goes home. But important thing to remember is that there is a scab that lies over the resection area, and often a week later that scab falls off, and it's common to see some blood again for a short period of time afterwards. Once a patient goes home after surgery, there's usually about a 5 to 7 day wait to get the results back. And the reason why it takes so long is that the specimens that we take out of the bladder need to be fixed, and then the pathologist needs to look at it and give us a full result. So it can take a few nerve-wracking days before you get the results back. The pathology results that you can get back after a bladder tumour has been resected can be quite complex. The first thing that we look at is what is the histology. And histology means what does it look like under the microscope. And the first question is it a bladder cancer? Now, bladder cancers are technically called urothelial carcinoma. And there's a few different varieties of them. The most common variety, which is 95% of bladder cancers, are called transitional cell carcinoma. But you can get rarer varieties which are called squamous cell carcinoma and adenocarcinoma as well. And knowing which variety is important because the treatments are slightly different depending on which variety it is. You can also, in addition to that, get some very rare tumours that occur in the bladder, and that's why the pathology is very important. The second thing we want to know is how deep has the tumour gone into the bladder wall, because again the depth of invasion determines what sort of treatment you're going to get as well. And we divide the depth of invasion into two groups. The first is called non-muscle invasive and the second is called muscle invasive. Non-muscle invasive means that the tumour hasn't invaded at all or has only gone into the first layer of the bladder, which we call the lamina propria. The second group, muscle invasive, means that the cancer has spread and invaded deep into the bladder and into the muscle of the bladder. Now that's a more serious condition because once it gets into the bladder, there is about a 25 to 50% chance that the cancer has already spread outside. And so it's very important for the pathologist to tell the urologist exactly what the depth is. The third thing that we look at is whether the tumour is high grade or low grade. And high grade and low grade, while they are both bladder cancers, are actually very, very different in the way that they act. Low grade tumours is the majority of tumours, about 75% of bladder cancers are low grade. These tumours, once they're resected, have the ability to recur quite frequently, and it can be about 50 to 70% over 5 years. But as long as they remain low grade, they really don't have the machinery available to invade. And it's only when a cancer invades that it becomes dangerous and it has the ability to spread. High grade, very different. High grade has got different genetic mutations in it, and it has the ability to grow rapidly and invade. And that's why we treat high grade very differently to low grade. So anyone with high grade cancer, it might not have invaded, but it does have that ability, so we do treat it differently. Once a patient has been diagnosed with bladder cancer, we first of all need to work out whether non-muscle invasive or muscle invasive. If they are muscle invasive, it is a more aggressive cancer, and there is a potential that the cancer has spread outside. So we need to do what we call staging. And staging means doing more investigations to see whether it has spread beyond. Often the patient has already had a CT scan of their abdomen and pelvis, and that looks at lymph nodes and liver within the tummy to see whether the cancer has spread there. In addition to that, we will often do a CT scan of the chest to make sure that there's no cancer there. And occasionally we will also do a bone scan which looks to see whether there's any cancer in the bones. Okay. If a patient doesn't have muscle invasive disease but has non-muscle invasive disease, generally all they need is a CT scan to make sure that it hasn't spread anywhere. And if that CT scan of the abdomen and pelvis is normal, then we can go on with treatment. Now, if unfortunately for the patient the cancer has spread beyond, in some cases we will do another test called an FDG PET scan. And an FDG PET scan can sometimes pick up cancer in the entire body, which might not be picked up by a normal CT scan.